Vardhaman Mahavir Medical College and Safdarjung Hospital. And as you can see, she has a lot of teaching experience, and her areas of keen interest are pediatric anesthesia, life support, and teaching. And she has several awards to her credit. She has several new publications in national and international journals, and she has been widely acknowledged worldwide for her works, including the World Congress of Anesthesiologists 2004, AS Annual Meeting at San Francisco in 2007, and World Cancer Congress Geneva in 2010. She's also the founder executive member of AMF, a founder executive member of Delhi IPA Society, a secretary of Delhi IPA, and life member of various anesthesiologist societies. We welcome you, ma'am. Moderating this session, we have our senior resident, Richa Sharma. She is the moderator and senior resident with us in RML Hospital. The case will be presented by Priyanka Singh. She is a postgraduate student at ABBMS and Dr. RML Hospital. Over to you, ma'am, for the proceedings of the session.
Thank you so much, Nitin.
Good afternoon, ma'am.
Good afternoon, Richa. Priyanka, you're ready? Okay. Since I am having a sore throat, so please don't mind my sound, my voice. And so we have Dr. Priyanka. She will be presenting her case, and the case is a hydrocephalus and meningomyelocele case. Okay, so Dr. Priyanka, please present your case.
Hello, good afternoon, ma'am.
Hello, good afternoon, Priyanka. You can start the case.
Ma'am, I'm presenting a case of 6-month-old male child, resident of Agra, brought by mother to the OPD with the chief complaints of swelling over the lower back region since birth, progressively increasing head size since birth, vomiting since 3 days, and poor feeding since 3 days. Mother informed child was born with the swelling over the lower back region since birth, which was initially the size of lemon, progressively increased to the present size of an orange, born with big size head, which progressively increased to the present size. History of vomiting 2 to 3 episodes per day since 3 days, which was non-bilious and projectile in nature. History of excessive crying present, no history of abnormal body movements, no history of bluish discoloration of skin, no history of recurrent respiratory infections or regurgitation of feed, no history of weakness of lower limbs. Birth history of normal vaginal delivery at a nearby hospital. The birth weight of the child was 2.8 kgs. The child cried immediately after birth. Since then, child was referred to higher centers where surgery was advised for the child. No history of admission to an ICU. Coming to developmental history, delayed milestones according to the age. The neck holding was achieved at 4th month of age and supine to prone still not attained. Immunization history, the child was immunized up to date as per the National Immunization Program. Antenatal history, a 30-year-old unbooked primigravida, non-consanguineous marriage, conceived spontaneously and confirmed it by a urine pregnancy test with no history of iron and folic acid intake, no history of fever, deranged blood sugars, seizures, smoking or alcohol or radiation exposure, no history of any medication intake. To summarize my case, a 6-month-old male child born by full-term normal vaginal delivery presented progressively increasing swelling on the lower back with progressively increasing head size since birth, history of vomiting and feeding since 3 days with delayed developmental milestones brought for ventriculoperitoneal shunt surgery. Journal physical examination. After getting consent from the parents, examination was done. The child was sitting on the lap of the mother. Child was irritable, lethargic, and not playful. Sunset sign was positive. No pallor, icterus, and cyanosis. Head circumference was measured to be about 56 centimeter. The length of the child was 55 centimeter, and the weight of the child was 6 kgs. Peripheral venous SS visible on the dorsum of hands. Pulse rate was 108 per minute, measured in right radial artery, regular rhythm, normal 90 by 60 mmHg in right arm. Respiratory rate was 22 breaths per minute, abdominothoracic type. Temperature was 98 Fahrenheit, measured in the axilla, and saturation was 100% on room air. Coming to local examination of the head was uniformly enlarged, measuring 56 centimeter, thin shiny scalp, distended scalp veins, anterior fontanelle was open, rhomboid, bulging, non-pulsatile, posterior fontanelle was closed. Examination of posterior midline swelling. A midline swelling was present at the level of L4, L5, 7 by 6 centimeter, hemispherical in shape, smooth surface, normal skin covering, non-mobile, cystic in nature, and no discharge from the swelling was present. Temperature of swelling was not raised in comparison to the surrounding skin, and transillumination test was positive. Airway examination, both nails were patent. There was no obvious recession of chin. Mouth opening appears adequate. Facial symmetry present. No external facial abnormalities present. Further examination could not be conducted since child was uncooperative. Coming to systemic examination, central nervous system. The child was lethargic, irritable, was opening eyes spontaneously and moving all four limbs. In eyes, sunset sign was positive. Tone and deep tendon reflexes were normal in bilateral lower limbs. No obvious cranial nerve deformity present. Examination of other system was within normal limits. My provisional diagnosis is a 6-month-old child with hydrocephalus and meningomyelocele with raised intracranial pressure, posted for ventriculoperitoneal shunt surgery.
Okay, so Dr. Priyanka, very nicely detailed presentation has been done. So you have given the diagnosis of hydrocephalus with meningomyelocele. Can we differentiate between a meningomyelocele and a meningocele in patients?
Yes, ma'am. Meningomyelocele is a neural tube defect which occurs due to failure of closure of the neural tube, leading to defect in the posterior vertebral arches, causing protrusion of meninges along with the neural tissues. Whereas in meningocele, there is only protrusion of meninges without neural tissues.
So that is theoretically. Can practically we differentiate between both of them? Is there any means?
Yes, ma'am. We can do a transillumination test.
Okay.
In meningocele, the transillumination test is positive, whereas in meningomyelocele, the transillumination test will not be positive.
Okay, maybe you can see some nerve roots in the, while you are doing transillumination, you can see the nerve roots. Okay. You have said this one, normally the children, do they present like this late for meningocele
No,
or
ma'am.
meningomyelocele? What is the usual time of presentation?
Ma'am, the neonates and the infants, they present late because in them, the fontanelles are open, so they can accommodate increase in the CHF up to a certain limit according to the intracranial pressure volume compliance. But in the older children, the fontanelles are closed, so they present with the sign of raised intracranial pressure.
Okay, that is regarding hydrocephalus. Regarding meningomyelocele, normally the children are presenting very early, not this late. This is a 6-month-old child. Normally, what is the usual time they are presenting and the surgery is being done in meningomyelocele?
Ma'am, surgery should be done within first few days of the life, since the surgery is prone to rupture and infection. And secondly, if we repair meningomyelocele earlier, then there is a decreased risk of ventriculitis and also progressive neurologic deficit.
Okay, that's good. Since this child has both hydrocephalus and meningocele, okay, does it occur very frequently? Both of them, do they exist very frequently?
Ma'am, in children of meningomyelocele, over 90% of the children, they are associated with Arnold-Chiari malformation, which is Chiari malformation type 2, where there is caudal displacement of the cerebellum, fourth ventricle, and the medulla. So, ma'am, in them, it's commonly associated.
Okay. What is the etiology of hydrocephalus in these meningomyelocele patients? How does this hydrocephalus come in this neural tube defect?
Ma'am, because Arnold-Chiari malformation is commonly associated in with meningomyelocele children in about 90% of the cases.
Yes.
So that leads to increased
Okay.
intracranial pressure.
Okay. So actually in the intrauterine life, many times there is a CSF which is circulating. The normal CSF flow is there. In case there is an open spina bifida, then this CSF is, that normal channel is not being followed. So that leads to a maldevelopment of the posterior fossa. And so the cerebellar diseases as well as the midbrain diseases do occur. So the cerebellum has a tendency to go down in the spinal canal. So it goes below the foramen magnum, and the midbrain has a tendency to go up. So you do find so many these diseases, the neurological diseases are present, and so the developmental milestones are also deranged. Otherwise, it's just a spinal cord disease. Why should the developmental milestones be delayed? So that is the reason that these things do occur in some of these patients. Okay. What are the other frequently observed symptoms? Like in this patient, you have given the symptoms, some other symptoms which are not there in this particular patient, but they are seen very frequently. What are those?
Ma'am, pertaining to hydrocephalus, the symptoms depends. It could be slow onset symptom or acute onset symptom based on the pathology and the site of obstruction. For slow onset hydrocephalus, the clinical presentation will be like the child will be lethargic, irritable, poor feeding, increase in the head circumference, sunset sign positive, delayed developmental milestones, weakness. Whereas in acute onset hydrocephalus, there will be signs of the child will be having vomiting, dehydration, severe headache, and
So
severe.
Priyanka, most of the symptoms, what you are saying, they're already present in this child. There are certain symptoms and signs which are present in children with meningomyelocele very frequently, which are not present in this particular child. What are those?
Ma'am, they can have sensory or motor deficit, and they can also have bowel and bladder involvement.
Yes, that is very, very common. So, see, we are supposed to be really looking out for these things, especially the lower limb, the paraplegia or the spinal cord deformities and the urologic symptoms, because in case there is a bladder involvement, then there can be kidney problems because of the back pressure changes. So those things will keep adding on through the morbidity in the child. In this patient, thankfully, these things are not present. Can you just guess what is the reason why this child presented so late? It is roughly 6 months old child. So why did this child come so late? Any guesses?
Ma'am, child. Yes, ma'am. And the child was since delivered in a nearby hospital. There, the parents were advised for the surgery to the child, but parents didn't come up to the hospital because the signs of raised ICP appear late. So maybe the lagging is from towards the parent side.
Okay.
Because the child didn't have any symptom earlier.
Is there any raw area in the back? No. There is no raw area in the back. Meningomyelocele? No, it is not there. Is there any oozing or any CSF discharge in the back? No.
No, ma'am.
That is also not there. So that is the reason probably those signs or symptoms, if they were present, then the parents would think that it is something serious and they might have brought the child much earlier. Okay. So what are the other associated problems which are there in these children? The common, the medical problems, what we see in these children with meningomyelocele, not hydrocephalus, that you have already described.
Meningomyelocele is commonly associated with hydrocephalus, Arnold-Chiari malformation, Vectral anomalies, club foot, neurogenic bladder,
Okay.
and ma'am, these children can also have frequent infections, like if the meningomyelocele is ruptured or if there is any discharge from the swelling.
Okay. Okay. This child is posted for a VP shunt. How will you further evaluate this child for surgery? Now, the child has come to you for PSC. Any further evaluation? Do not repeat the history or examination. Just tell me any further thing.
Ma'am, after obtaining a detailed history and examination, I would like to ask for certain lab investigations like complete blood count, including hemoglobin,
Yes.
serum electrolytes, and the chest X-ray to rule out any cardiac anomaly. And after getting the required investigations, I would like to optimize the child. So I will examine the swelling of the child, meningomyelocele, using a latex-free gloves. I will look for any discharge from the swelling or any rupture, or if the swelling is ruptured. If the swelling is ruptured, I'll cover the swelling with a saline-soaked gauze to prevent contamination of the swelling. I'll also give antibiotics to the child. I will prevent drying of the lesion. Is the eruptive heat. So the loss, I will for signs of dehydration in the child, like dry mouth, dry lips, sunken eyes, poor skin turgor, and high colored urine. So I'll preferably give ringer lactate to the child. And I'll also look for dyselectrolytemia. And if present, I would like to correct the electrolyte imbalance. I will avoid hypothermia and continue anticonvulsants if the child is on any anticonvulsant medications.
Okay,
Then
good.
after optimization, I would proceed further by giving the pre-op orders. So I will counsel
Hold on. Okay, so you have further optimized and evaluated the child, and apparently everything seems to be fine other than a bit of raised intracranial pressure. So what are the other your concerns as an anesthesiologist when this child with hydrocephalus and MMC is coming in for surgery? Your concerns, can you briefly tell me those? Just enumerate, no details.
Okay, ma'am. My anesthetic concern for this child who is undergoing a ventriculoperitoneal shunt, I'll try to divide it into age-related concerns, disease-related concerns, and the surgery-related concerns. My age-related concerns will be airway will be difficult. They are prone for hypothermia, and they have increased volume of distribution and poor clearance for most of the drugs. They have immature liver and renal system. They have small veins, so venous access can be difficult. And then disease-related concern, since the head is large in hydrocephalus, so there will be difficulty in positioning the child. And so I would like to keep the bolsters to be kept beneath the shoulders so that it compensates for the large head. And secondly, since the head is large, so the flexion of head and neck can also cause airway obstruction. So I'll be careful regarding that. And pertaining to meningomyelocele, I'll keep a adequate size donate to protect the meningomyelocele, and I'll be cautious about latex. Surgery-related concerns will be since the surgery is to be done in supine position with the head towards the opposite side, so I'll be careful to see that there shouldn't be any excessive twisting of the head. And second concern will be during the ventricular puncture, there is sudden release of the intracranial pressure that can lead to bradycardia, hypotension, and even herniation of the brain. And next will be during the subcutaneous tunneling, there is increase in the sympathetic response. So for that, I will try to deepen the plane of the anesthesia, and I'll take care of hypothermia. I'll maintain normovolemia in the child and avoid hypoglycemia, hypoxia, and hypercardia.
Okay. So now what are your preoperative orders for this child?
Ma'am, for the preoperative orders, I would like to counsel the parents regarding the planned procedures, and then I'll take a written informed consent. I'll explain about the guidelines, 2 hours for clear liquids, 4 hours for breast milk, and 6 hours for solids. I would ask for morning serum electrolytes on the day of the surgery.
Okay. And what is your plan of anesthesia? Because the surgeons would like to do a meningomyelocele as well as a VP shunt both done together. Because if meningomyelocele is present, they will definitely close it as soon as possible. Okay. So they plan to do both the surgeries. So they will do the meningomyelocele first, followed by the VP shunt placement. So how will you proceed? What is your plan? You've already done the pre-medication, the pre-operative orders have been given, everything done. So
Ma'am,
would
my
you like
plan
to
of
pre-medicate this child?
no, ma'am, I would not like to pre-medicate this child because since the child is already lethargic and have CNS depression and also signs of raised intracranial pressure.
Okay, good. So then what is your plan for anesthesia? How will you induce this child?
Ma'am, my plan of anesthesia for this child will be general anesthesia with endotracheal intubation with controlled mechanical ventilation. Before proceeding towards the surgery, I would like to do some OT preparations. Like I set the OT temperature between 26 to 28 degrees Celsius. I'll keep a temperature controlling matrix spread over the OT table. I'll ensure the availability of fluid warmers inside the OT. And instead of making adult IV set, I'll prepare burette set for the child, and I'll make sure that there is no air in the IV set. I'll keep the pediatric circuit, and I'll keep the endotracheal tube of size 3.5, 4 and 4.5, and Miller's blade 1. I'll keep IV cannulas of size 22 gauge, 24 gauge, and 26 gauge. I'll check the suction. I'll check the pediatric defibrillator. I'll prepare IV drugs, both emergency and general anesthesia drugs. And for the positioning of the child, I'll keep the bolsters and adequate size donut inside the OT. Then before taking the patient inside the OT, I'll once again check for any fresh complaints in the patients and look for the written informed consent and check the morning serum electrolytes. Then I'll take the patient inside the OT, connect all standard ASA monitors like ECG, NIBP, pulse oximetry, temperature monitoring, and capnography. And if IV line is present in the child, I would connect warm IV fluids, and then I'll proceed.
Wait. If the child is lethargic and not feeding and has been vomiting over 3 days and right now he's admitted in the hospital, is it likely that he will have an IV line? Most
Yes,
likely, yes. So we take it that the IV line is present. So how will you proceed now to give general anesthesia?
Now proceeding towards induction, I'll first, since my plan is general anesthesia with endotracheal intubation, I'll make a proper positioning. So I'll keep a bolster beneath the shoulders to compensate for the large head so that oropharyngeal laryngeal axis come in one plane, and also adequate size donut to protect the meningomyelocele. Then I'll proceed by giving injection fentanyl 2 mics per kg, injection thiopentone 5 to 6 mg per kg. Then I'll look for the eyelash reflex and ensure the ventilation.
So before we give any drugs, should we put some monitors over the child?
Yes, ma'am. I'll attach all standard ASA monitors.
Okay. You have attached the monitors. Just enumerate which all monitors you have put on.
Ma'am, I'll attach ECG, pulse oximetry, NIBP, capnography, and temperature monitoring.
Capnography and temperature are done once the patient has been, induced, but not before that. Okay. So you will use them as and when you can use them. Okay. So then how are you inducing fentanyl? And
then I'll proceed by giving injection thiopentone 5 to 6 mg per kg. Then I'll look for the eyelash reflex. I'll ensure the ventilation of the child by giving small positive breath. And if I'm sure that I'm able to ventilate the child, I'll proceed towards giving the muscle relaxant, injection etracurium 0.5 to 0.6 mg per kg. And then I'll ventilate for 3 minutes and then secure the airway using endotracheal tube intubation.
You plan to use a cuff tube or an uncuffed tube?
Ma'am, uncuffed tube.
Okay. Why? Why do you plan to use an uncuffed tube? Why not a cuff tube?
Ma'am, I would plan for uncuffed tube because in children, the narrowest portion is at the subglottic region. So that's why, ma'am.
that is subglottic region. But then by an uncuffed tube, the child would be put first in supine, you are putting in a tube, then the child will go prone, then you will again make the patient supine for hydrocephalus and for reversing. So we just, what do we want? We just want the ability to control the ventilation. So now with the microcuff tubes, why not a microcuff tube? It's always better to ventilate with those tubes. You cannot ensure an airtight seal with an uncuffed tube in small children. Okay, because the cricoid is nowadays, the further studies have found out that the cricoid is not, circular. It's more elliptical. So then you can still have leakings from the side of the tube, even when the pressure is there on the walls. So it is better to have an uncuffed tube. Okay. Okay, it's fine. So you put in a tube. Many of us are still putting uncuffed tubes, but whenever possible and we get it, we do use cuff tubes. Fine. So you put in a tube and thereafter.
Then I'll position the child for the surgery. Since the surgery is done in supine position, but head towards the opposite side.
Wait. We said first an MMC surgery, so the child will go prone. How will you maintain anesthesia? Just tell me that.
Ma'am, on shifting the patient from supine to prone position, I'll first disconnect all the IV lines, and then I'll switch the patient to the prone position, and then I'll once again check for the bilateral air entry, because there are high chances of endobronchial intubation or endotracheal tube dislocation or disconnection while switching the patient from supine to prone. I will I'll make sure the eyes are well padded and all the pressure points are well padded, and abdomen should be free, because if there is increase in the abdominal pressure, that will cause increase in the epidural venous pressure, and there will be increased risk of bleeding.
Just tell me, for maintenance of anesthesia, how will you maintain anesthesia? Quick, no explanations.
I'll maintain my anesthesia on 50% oxygen, 50% air, plus inhalational agent with sevoflurane with MAC less than 1.
What is the disadvantage in case you use nitrous oxide?
Ma'am, since nitrous oxide has a vasodilating property, it will cause increase in the cerebral blood flow and thus causing increase in the intracranial pressure.
Okay, but what is specifically contraindication in a case of hydrocephalus? What is the problem in hydrocephalus?
Ma'am, ICP, there is increase in the intracranial pressure, so that's why I would like to. Because it increases the.
Okay, when they are doing the surgery, wait, listen. When they are doing the surgery, then there can be some air bubbles which are going inside, so they can later expand further. So it is better that we don't use nitrous, but even when nitrous is used, it is okay. We can still go ahead. But in hydrocephalus, wherever there's an open cranial surgery, we are trying to avoid using that. That's it. Okay. Inhalational agent, what is the problem with inhalational agents in case we use sevoflurane or isoflurane? What is the disadvantage of using inhalational in a CNS surgery?
Ma'am, all the inhalational agents, they cause decrease in the cerebral metabolic rate of oxygen and they have vasodilatation property with, but they are in balance at MAC less than 1. But once it's MAC more than 1, then the vasodilatory property predominates over the decrease in the cerebral metabolic rate. Okay. So we should maintain the MAC less than 1. And for ISO and sevoflurane, ma'am, the potency of vasodilating effect of...
We stop here. We stop. The other important thing is the latex thing, which occurs in meningomyelocele, and the CSF loss, which we should take care. Okay. And I think because the time is very less, we let Richa show her presentation further. Okay, Dr. Richa, please share your slides.
Yes, ma'am. So here's a brief summary on meningomyelocele and hydrocephalus. As we've already discussed, meningomyelocele is a type of neural tube defect, which is a defect in the primary neurulation process, which occurs between 18 to 21 days of gestation, Our central nervous system, it develops from a neural plate, which then forms a neural groove in the midline. Then this groove acts as a hinge and the neural plate will fold upon itself to form a neural tube. If there is any defect in formation of this tube, then there will be an area through which meninges alone or meninges along with the neural structures can herniate. If they herniate, just the meninges herniate, then it is a meningocele. And if both the nervous tissue and the meninges herniate, then it is known as a meningomyelocele. The etiology of meningomyelocele is genetic factors, which are most commonly trisomies 13 and 18, single gene mutation, inadequate folic acid intake by the mother during pregnancy, viral infections, hypervitaminases A, pregestational maternal diabetes mellitus, irradiation exposure to the mother during pregnancy, intake of salicylates, carbamazepine, valproic acid in early pregnancy, and defect in embryogenesis. The associated anomalies with meningomyelocele are Chiari-2 malformation, which also includes hydrocephalus, cranial nerve dysfunction, and seizures. It is also associated with bacterial anomalies, which includes vertebral anomalies, anorectal defects, tracheoesophageal fistula, and limb defects. We also have renal anomalies, which will present as renal failure or neurogenic bladder. There could be cardiac malformations. There could be club feet, absent ribs, scoliosis, hip dislocation, which can present as paraplegia, joint deformities, or pathological fractures. There could be facial clefts or umbilical hernia as well. Then coming to brief about hydrocephalus. Hydrocephalus is derived from a Greek word, which means water on the brain. It is basically a mismatch between CSF production and absorption, which will ultimately lead to increase in CSF volume. And the increase in ICP, that is intracranial pressure, will depend upon if the fontanelle are open or closed. The normal cerebrospinal fluid formation rate is 0.5 ml per minute. And the normal volume of CSF is 150 ml, of which 125 ml is in the spinal compartment and 25 ml is in the cranial compartment. Normal intracranial pressure is 1.5 to 6 millimeters of mercury in term infants and 3 to 7 millimeters of mercury in children. Now, pathway of cerebrospinal fluid is, it is formed in the lateral ventricles by the choroid plexus. From the lateral ventricles, it goes into the third ventricle via interventricular foramina. Through the then from third ventricle to the fourth ventricle, it goes via cerebral aqueduct. And from the fourth ventricle, it goes into the subarachnoid space via lateral and median apertures, which are foramen of Lashka and foramen of Megendie, respectively. From there, it goes into it is absorbed by the arachnoid villi and goes into the dural venous sinuses and is absorbed into the bloodstream. Now, based on the ability of cerebrospinal fluid to flow around the spinal cord, we can divide hydrocephalus into a non-obstructive type or an obstructing type. Choroid plexus papilloma, achondroplasia, craniofacial syndromes, and tubercular meningitis will lead to a non-obstructive type of hydrocephalus, whereas congenital aqueductal stenosis, tumors, post-inflammatory adhesions, meningitis, post-subarachnoid hemorrhage, Chiari-2 malformations, and Dandy-Walker syndrome will lead to an obstructive type of hydrocephalus. Management of hydrocephalus is mainly by diuretics, acetazolamide, intermittent ventricular tapping with or without an Ommaya reservoir, external ventricular drainage, CSF diversion procedures, which most commonly is ventricular peritoneal shunt, but there can be ventricular pleural, ventricular atrial, or ventricular cisternal shunts as well, and endoscopic third ventriculostomy. Ventricular peritoneal shunts can be of two types, fixed pressure types or a programmable valve types. In the preoperative assessment, we will look into the history with onset and chronicity of symptoms, change in the size of swelling in the head, consciousness, lethargy, headache, irritability, vomiting, poor feeding, dysphagia, seizures or increase in the seizure activity, gait disturbances, diplopia, and also the history of previous surgeries, birth and immunization history. On examination, we have to look for the large head, widening of the sutures, bulging fontanelles, nutrition, dehydration, crackpot sign, which is not commonly done these days, papilledema. We have to look into the other syndromic features, signs of tubercular meningitis, tumor and hemorrhage, because they are just the differential diagnosis of other causes of hydrocephalus. We have to go for the inspection and we have to go for a transillumination test. Then we look into the signs of increased ICP, which is frontal bossing, dilated scalp veins, cranial nerve palsies, bradycardia, hypertension, and changes in respiratory rate, which form the Cushing's triad, depressed consciousness, and seizures. Then we also look into the other systems. Anesthesia management includes the monitoring, all the ASM monitoring, including glucose monitoring in neonates. Now, position is a major concern for induction and intubation for both the induction for the hydrocephalus surgery as well as the meningomyelocele surgery. We don't want a direct pressure on meningomyelocele, so we use a donut cushion. We can go for RSI depending upon the condition of the patient. If the patient is having vomiting or if it is an emergency surgery, we can go for inhalational or intravenous induction. Our IV fluids will be balanced salt solutions, which are mostly isotonic, and we can also use normal saline. Analgesia would be short-acting opioids like fentanyl or remifentanil if available. We can use intravenous or per-rectal paracetamol, and we may need post-op ventilation as per the patient's condition. So this is the position we usually take. The child's back is supported by a pillow and the toes and the MMC can be here supported by a donut. Now, this is the main slide in which I have summarized the anesthesia goals and challenges. Our challenge is the age of the patient, which is pediatrics age group, and all the physiological changes which are associated with them. Then there could be coexisting diseases, which we have enumerated just now. There is a difficult airway because it is a pediatrics case along with a large head due to hydrocephalus. So that is to be looked into. The position is a concern for intubation as well as surgery. All the prone position precautions have to be taken into mind, like padding of the patient, eyes have to be checked, the endotracheal tube can be dislocated. So all that has to be looked into, and even the IV lines may be a concern as patient is already dehydrated along with it's a pediatric case. So we have to manage the blood, fluid, and electrolytes. We have to avoid hypothermia, hypoxia, hypercarbia, and venous engorgement in these patients as it will lead to increase in ICP. We have to look into that there is no aspiration. The cardiorespiratory responses during ventricular puncture, blood loss, intubation, and brainstem compression have to be looked into. The pain during tunneling is to be addressed with short-acting opioids or paracetamol. And latex allergy, as already discussed, we have to prevent hypoglycemia, specifically in neonates. And then we may also need a post-op ventilator for these patients. Thank you.
Thanks, Richa, for summarizing it so well. You have just completed everything.
Thank you, ma'am.
Good, Priyanka.
Thank you, ma'am.
Most of the key features you have already said. So I think if any questions are there, we can answer those. Any questions?
No, ma'am, there are no questions in the chat box.
Okay. Fine.
Thank you so much, ma'am, for such a nice discussion.
Thank you. I'm sorry for my throat, but these people have done most of the job. Thank you. Okay.
So we'll move on with the next session, which is on BLS and ACLS. I would like to invite the chairperson for this session, Dr. Sanjay M. Masi, Service Professor in Anesthesia and Critical Care at FH Medical College, Agra, And sir's area of keen interest are trauma and emergency anesthesia and critical care. We welcome you, sir. Over to you, sir, for the proceedings of the session.
Well, thanks for inviting me here and making me a part of the proceedings. And I think this is a wonderful opportunity for all the students to listen in and learn so much.